The system I am currently using is available only off-label in the United States. In the rest of the world, it is approved for use as a total resurfacing device. It comes in even sizes every 2 millimeters from 38 to 60. Implant thickness is approximately 3 to 6 millimeters in the acetabulum and 0 to 6 millimeters in the femur, being 6 millimeters at the apex and tapering to 0 at the edges. The inner diameter to outer diameter difference for the acetabulum is 6 millimeters. This is important to remember. All instruments are color-coded for size. Only one femoral component fits each acetabular component. The acetabular component sizes are actually sized. I recommend 1 to 2 millimeters of underreaming. My overall strategy for sizing implants during surgery is as follows. First, I would preoperatively template x-rays for an approximate size. Next, during the surgery, the femur is mobilized. We measure the femoral neck, and we base the femoral size on this. Usually the femoral head is prepared 1 to 2 sizes, that is, 2 to 4 millimeters above the size of the femoral neck. A trial component is then placed, and we turn to the acetabulum. The acetabulum is reamed, and the proper acetabular component is placed. We then turn back to the femoral side, and at this point, we can readjust the size of the femur down 1 or 2 sizes, if necessary, to match with the acetabular component placed. It is rarely, if ever, necessary to use a larger femoral component. If this is the case, extra cement could be added and a larger femoral component could be placed. Clinical results to date are reported in 506 patients with follow-up of 6 weeks to 5 years. 2/3 are male. The average age is 49. The Harris hip score increases in a similar fashion to standard total hip replacement. Many patients are involved in sports or strenuous work. The most common complication is femoral neck fracture in approximately 1%. They always occur between 6 weeks and 6 months post-operatively. Early femoral loosening or osteonecrosis occurs in approximately 0.5%. There is a low rate of other complications. There are no dislocations. Overall, a total of 10 revisions have been required for a rate of 2%. There was one late intertrochanteric fracture unrelated to hip surface replacement. The recovery is generally quite rapid. At 6 weeks, rehab is advanced, and at 6 months, full vigorous activity is resumed. There are only a few specialized instruments required. These include standard and customized Taylor and Meyerding retractors, 2 double-angled Holman retractors, and a Mueller retractor. Here you can see the instrumentation supplied by the manufacturer, which is required for preparing the femoral head. These are the instruments required for the acetabular preparation.